welcome everybody. I'd love to introduce you to Dr. Sarah Wheeler. Sarah is an associate professor at the University of Pittsburgh, Department of Pathology. She's also a medical director of clinical chemistry at the Children's Hospital at UPMC. She's the medical director of automated testing at UPMC Mercy Hospital and the associate medical director of clinical immunopathology at UPMC. Her research interests include infectious diseases such as COVID, HIV, syphilis, Lyme, hepatitis. She works with rapid point-of-care diagnostics and the effects of viral infections on autoimmunity, machine learning, appropriate serological testing in children, and immune dysregulation. Dr. Wheeler completed her doctoral work at the University of Pittsburgh in cellular and molecular pathology. She completed a combined basic research and clinical postdoctoral fellowship at the University of Pittsburgh in metastatic breast cancer and clinical chemistry, respectively. Since her postdoc, Dr. Wheeler has worked in both industry and academic medical centers, combining research and clinical duties. She is credentialed by the National Registry of Certified Chemists and is a fellow at the ADLM Academy here. So welcome, Dr. Wheeler.
Thank you. It's a pleasure to be here.
Yeah. So we've been hearing in the news a lot about syphilis. What's going on and why are we hearing about syphilis?
Yeah. So, sorry, I'm going to move through. This is why we are hearing about syphilis. So the data was just released this year from the CDC for the 2022 statistics around STIs. So this is one of the infographics that the CDC has provided for us to see what's going on. One of the things that's a little bit frightening is that if you look at the congenital syphilis cases, we're up almost 1,000% over the last 10 years. And this is particularly heartbreaking because that shouldn't happen to anybody in a developed country. And when these children are born, we often will not see any symptoms until they're older, and there's honestly nothing we can really do about it. One of the other things that's a little terrifying is that this will not all be scary, I promise. But one of the things that's a little terrifying is this is the highest number of new syphilis cases that we've had reported since 1950. Those are not the kinds of things that we want to have happening. So we don't have monetary analyses of the 2022 data yet, but on the 2018 data, syphilis alone had direct medical costs nearing $200 million. Given the increase between 2018 and 2022, we are now north of $200 million in direct medical costs for a preventable disease. So there is a reason this is hitting kind of all of the top newspapers and news outlets, and it's because these are not the direction that we were hoping we would be going in this kind of post-penicillin era when we could be treating this.
That's right. So what are the key manifestations of syphilis? What should people be looking for in symptoms, and how does it progress?
Yeah, so kind of a little bit about syphilis generally. Historically, syphilis has kind of had this mystique about it because it can present in many different ways. It has a lot of symptoms and signs. And one of the reasons that CDC data tracks this kind of primary and secondary syphilis is because during the primary and secondary stages is when it's most contagious or most transmittable. And in the primary stage of syphilis, there's this painless chancre or sore that pops up, and it often goes unmissed. To be honest, in many populations, we catch primary syphilis in less than 50% of cases because people just don't realize that sore is present. Secondary syphilis happens when we start getting a rash everywhere, particularly kind of the hallmark is the palms and the soles of the feet. And as we move beyond primary and secondary syphilis into latent syphilis, all of the symptoms resolve. So clinically, these patients are asymptomatic. We don't have a way of knowing that they have syphilis unless they're tested for it because there aren't any clinical symptoms. And when we're looking at early syphilis, early latent syphilis, that's going to be less than a year since exposure. Late latent, we're getting into all the alliterations here. Late latent syphilis is going to be greater than a year since infection or unknown. And one of the things that's a little bit promising about this data is that we're seeing an increase in primary and secondary cases, which tells us that we've got a lot of screening happening. So we like that we're at least catching those at that point. And that does seem to really be, primary and secondary is leveling off a bit, but our unknown duration or latent is increasing, which means we're doing more screening. So we're catching more cases that we didn't catch in the primary and secondary stages, which may be preventing this steeper increase. So while the total syphilis is going up, we are perhaps seeing that our screening is working and helping. And then kind of at any stage, we can have neurosyphilis, otic syphilis, or optic syphilis. And those are all the manifestations that we kind of read about in pre-penicillin days as well.
So we just talked about the stages. Can you walk us through how do we test for syphilis? Since we're all laboratorians and that's what we're focused on, what do we do to screen for syphilis?
Yeah, so syphilis screening is, for better or worse, a little bit complex. We don't have a single screen that we can do that tells us, yes, this is for sure syphilis, and yes, this is active syphilis that hasn't been treated. So I failed to mention that syphilis is a spirochetal or bacterial infection. And fortunately, with spirochetal diseases, we don't see a high enough level of bacteria in the blood to be able to directly detect that bacteria. So we have to use the body's immune response. So we're going to detect two different kinds of antibodies, generally speaking. So we're interested in the treponemal antibodies. So those are going to be against the spirochete itself. We're looking for proteins that are carried by the bacteria. We call those treponemal assays because they're from the treponema. Those assays, modern assays, are highly automated. They include IgG and IgM in them. So we're catching kind of an earlier window of syphilis than we would have with older assays that were IgG only. Then we have some new CDC guidance out that is also changing a bit of our nomenclature. So many of us have heard about non-treponemal tests. This would be VDRL, RPR. We're used to talking about them as non-treponemal because they're against antigens that are not present on the bacteria, is what we thought. But it does turn out that they're against lipoidal antigens, cardiolipin, cholesterol, phosphatidylcholine are the antigens that really these antibodies are created against. And it turns out that some of those are present on the treponema in kind of current literature and current understanding. So there has been a shift to trying to call these lipoidal antigen assays, which is even more of a mouthful than non-treponemal assays. So I still call them non-treponemal assays, if we're being honest. I may just refer to them as RPR as we continue talking, because that's what I'm used to. But there are kind of a few limitations. So these lipoidal antigen assays, we expect that response to go up during active syphilis, and then kind of as if people are untreated as they move through latent syphilis, that can still kind of naturally, the titers will decrease. It's a semi-quantitative assay. If people are treated, we expect at least a 4-fold decrease in those non-treponemal titers. And that helps us know that they had a robust response to treatment. About 10% of patients are going to continue to be serofast. So they will not convert to a negative titer or a 0 titer on the RPR or non-treponemal assay. So they will need to kind of continue to be followed and look for an increase if we're concerned about reinfection. Once you're positive for treponemal assays, most people are going to be positive for the rest of their life. So we will continue to detect those in people that have treated and resolved disease. And then I guess the one other thing that is a limitation of these assays, talking about these assays, is that in our lipoidal antigen assays, one of the things that can happen is prozone. So there has been a thought that prozone is simply due to very high levels of antibodies that do not allow the agglutination or flocculation to take place. More recent literature indicates that there may also just be an interferent. So when we refer to prozone, we usually mean it's a sample that when you test it neat, it's negative. As you dilute it, it starts to become positive. And it looks like it may not always be antibody excess, but that it is actually also some interferents that are present. And in some populations, we can see this in a reasonably high number of people.
which is kind of a limitation, right, of that side of the equation.
Yeah.
So thanks for that biochemistry background. Appreciate it. With those two kind of pathways, there must be different algorithms of how we walk through this. Could you walk us through the two that the CDC talked about recently?
Yeah. So syphilis testing is a little bit confusing. We still get lots of questions about it. And there are two algorithms we use, a reverse algorithm and a forward or traditional algorithm. So in the forward or traditional algorithm, we start with that non-treponemal test or RPR test. So we're looking first for active syphilis. If that's positive, then we send that positive to treponemal testing and see, is that reactive because it's syphilis? Because again, we're looking at lipoidal antigens, and it turns out there's some cross-reactivity with certain patient populations or conditions. If the treponemal is also positive, we say, yes, this is syphilis specific. We should treat it. If it's negative, then likely the RPR is what we would call a biological positive. Looking at the reverse, we start instead with the treponemal test. Again, the treponemal tests are highly automated, so that can be really helpful. And we started seeing the reverse algorithm really as automation came online. So we're looking for if you've ever been exposed to syphilis, really, at the beginning of this algorithm. And then we test for non-treponemal, if that's positive, and say, is this active infection? If the non-treponemal is negative, we're going to double check that that first assay wasn't a false positive. So we're going to run a different treponemal test. It's recommended that you use very high specificity tests. TPPA is kind of our most specific test, debatable in the literature, but it's very commonly used as the second treponemal test. If the first and the second test agree and are both positive, then likely active syphilis, and we should start treatment.
Treatment, yeah. So, two algorithms. What is new about what the CDC, talked about, and with the epidemic that we're having, how can the lab actually participate in helping the situation?
Yeah. So one of the things that is, syphilis is not all good news, obviously. We don't want this to be happening. But as laboratorians, we actually can do something about this, which is really exciting. And we play such a large role that for the first time ever, the CDC has released guidance on how the laboratory should test for syphilis, because screening is such an important part of this. Very quickly, patients become non-symptomatic, and that causes us issues in terms of spreading syphilis. So a few just kind of highlights from the CDC recommendations that may be a little bit different than what we're doing in the lab right now. Also, I'm not going to read to you all of this, but these are quotes from the CDC guidance. And I do love this top one, that really clinical laboratories are critical to our response to syphilis. And it's not too often that we hear that about something that's happening. So again, a few things that are perhaps different. There is the recommendation that we run full algorithms. So very often hospitals will have just RPR or just treponemal screening, and there will be no reflex to the full algorithm. Even if that full algorithm isn't in-house, having a reflex to a send-out ensures that people are getting the full testing to know if they should be connected to treatment. Also, in some of the automated assays for non-treponemal testing, and in some assays as we're running them in-house for non-treponemal testing, we titer to a certain point and we report out greater than. Some of the automated assays don't titer all the way down to like a 1-to-1 titer. And the CDC is recommending that we do not use greater than or less than, but that we provide the end titer for non-treponemal testing. And then that also, if the instrument says, say, less than 1-to-4, that we make sure that we do a manual titer. We do a neat titer on an alternate method. There are also some specific recommendations for pregnancy that have come out in this, making sure that when we're screening for congenital syphilis in children, that we're not using cord blood, so there can be maternal contamination, obviously, and some false positives with the Wharton's jelly that can be present there. And there's some laboratories also will use IgM-specific tests to screen for syphilis in babies because IgM can't can't cross that barrier. And so we assume that it will be local. CDC does not recommend any IgM-only tests, but rather that we measure RPR on baby and mom simultaneously using the same non-treponemal method and compare those titers.
So one of the things I noticed there too is they want you to test 3 times during pregnancy, right? When you look at the data, we're obviously not testing enough in pregnant moms. So just adding. Right.
Yeah. And so we are likely to see within our clinical laboratories as public health agencies are rolling out increased screening measures, as more people coming through our emergency departments are being screened for STIs, we are likely to see increases in our volumes. And so we have to think carefully about how we're managing that on the laboratory side, given that a significant portion of this testing is manual or is currently sent out, which is also of concern.
Yep. So we've talked about algorithms. We've talked about the CDC. We're going to kind of do a loop now. And are there specific considerations if you're doing one of these algorithms versus the other?
Yeah. So there's been very interesting information kind of in the literature about algorithms. So a lot of this testing has been around since the 50s and 60s. And so we have a lot of historical data on it. And we are missing some data, to be honest, on some of the updated tests for, say, highly automated treponemal testing. We don't have all of the data that we need in the literature. But when we're looking at forward versus reverse screening, one of the primary things to remember is what patient populations you're going to be identifying. So in the forward screen, we start with non-treponemal testing. Non-treponemal testing, we have positives that are associated with syphilis, and then we also have what we call biological false positives. So we're looking at antibodies against cardiolipin, cholesterol, phosphatidylcholine. Those antibodies show up in other things. So autoimmune diseases have kind of an increased prevalence of antibodies against this. There's some literature around vaccination, immune response to vaccination, particularly if those vaccinations have lipid envelopes in them. We will have antibodies that can cross-react because they are lipid antibodies. Any kind of acute viral infection, inflammation, anything where our body's creating a lot of antibodies, we can start to see some biological false positives in RPR testing. And it varies by population, but kind of on average, if you look at all of the studies, as much as 10% of the population can have biological false positives when being screened by RPR or non-treponemal testing. The other thing about non-treponemal or about treponemal versus non-treponemal is that treponemal testing will become positive anywhere from 2 days to 7 days before non-treponemal testing. It depends a little bit on which paper you read, but we're going to see treponemal testing become positive just a little bit earlier. So the window period is a little bit smaller. So that means that in forward testing, we're going to see some biological false positives that are going to pop up. That can be concerning if you're screening, say, a pregnant population, where being a biological false positive for syphilis is a very stressful event. And then if we add to that the fact that, thankfully, our maternal population tends to be a low prevalence population. And so we also have that kind of increased false positives that we expect to find due to pretest probabilities in a low prevalence population. If we look at the reverse algorithm, we still have the kind of pretest probability issue. We're going to see increased false positives if you're testing a low prevalence population, but we're likely to catch earlier syphilis. So we're getting kind of that earlier window. And then we also missed, when we're screening with the forward algorithm, people who had syphilis and their titers naturally waned, but we never treated them. We're going to miss them with our forward. So there are cases of latent syphilis that we're missing with forward, but we will catch with reverse. So overall, in the literature, we're going to catch the most cases if we use the reverse algorithm. Kind of that said, we don't all have automated treponemal testing available within the labs we're running. And so forward testing may be the best way for us to get some screening done in-house to connect people to care. And it may also be kind of what is feasible financially as well, because still non-treponemal testing tends to be less expensive than treponemal.
Except for the manual part of it.
There's the manual part. The RPR is like an 8-minute test, I think.
Yeah. So what are some of the gaps that the lab can get involved in to help close those in syphilis testing?
Yeah. So we unfortunately still have a lot of gaps in syphilis, people who get syphilis, as well as in syphilis screening. So the data that the CDC released also revealed that we still have care gaps. Unfortunately, syphilis is still disproportionately affecting minority groups and populations. And part of that's because we're not providing testing where people seek care. Syphilis testing is often still a send out or is not available as people are in the emergency department. As they're seeing their PCP, they may have to go somewhere else to get a blood draw and get that result back and be connected to care. One of the great things about syphilis screening is that the treatment is generally a single dose of penicillin for most people. So if we can identify people who have active syphilis, we can connect them immediately to the treatment they need, rather than it being a very extended treatment for the most part. We also still need kind of more studies on the updated modern assay performance. So there are a lot of gaps in our understanding of how modern treponemal methods compare to kind of treponemal tests from the 80s that were very manual. And CDC has stated in their kind of updated guidance for us that they need better data from us. So making sure that our laboratories are providing data to public health agencies is really important, and that data is accurate and high quality, that it's not just kind of the first part of the algorithm that gets to them, but that they're getting the full algorithm and in a way that's interpretable for them. Things like making sure that full titer data is available to the public health agencies definitely comes into that.
Okay. Well, thank you very much for that. Basically, we're at the end of our talk, and I'm going to open it up to questions from the group. But before I ask them, maybe I'll ask you, what do you do in your lab to screen for syphilis? What algorithm do you use?
Yeah, so currently the lab that I'm immediately over, we do the reverse algorithm. So we have the ability to do treponemal testing, and we do that. As a system, I'm part of a large healthcare system, and we have started an initiative to standardize our syphilis testing and make sure that it is available in all of our hospitals. So some of our rural hospitals, traditionally, kind of all serology has been thought of as a send-out test. It's not urgent. We can send it out. There's no need for us to do it in-house. And so we're assessing how many hospitals we have like that, what capability do we have to bring in, and acknowledging that in some of those hospitals, they don't have the instrumentation to run a reverse algorithm. And so we may have to consider a forward algorithm where they run the first test in-house and then send out the rest so that we're not getting the attrition.
Unless you get one of the smaller machines from here. No? All right. I'll open it up for questions. Anybody? Liza?
Thanks. I heard you mention, David, that there's now recommendations to screen for syphilis multiple times in pregnancy.
Right.
Yet Dr. Wheeler was commenting about these high and increasing rates of perinatal transmission. I don't think all of those are patients who haven't had any prenatal care. So what opportunities do you see, Dr. Wheeler, to test patients in settings or in ways that we're not currently capturing?
Yeah, so I will say, unfortunately, when we look at the kind of the cases of congenital syphilis, it tends to be high among the IV drug users. So that's a major increase. And we're not seeing that they're actually getting the prenatal care that we would expect. So I think that's a place where in kind of that population, we see them coming to our emergency department. And so having STI screening as a standard of care part of an emergency department workup is a real opportunity, not just for syphilis, but for other STIs to make sure that we are getting people the care that they need when they are where they're going to seek it. I think something else that I would love to see more of is point of care syphilis testing so that we can take the testing to them. So we've maybe thought about chronic diseases a little bit this way. You know, let's have some point of care A1C testing so we can take it to, you know, the local get-togethers that people are having. I have seen some little point of care testing booths at some of our, like, fairs is not the right word anymore, like street carnival things. Everybody's out.
Right.
And, you know, that's a place where we could have things like syphilis testing so that we are bringing it to where people are, and getting them connected to care is much easier for something like syphilis than for some of the other infectious diseases. Thanks.
Any other questions?
We've got a microphone.
Hi. I was just curious if you could comment on PCR for syphilis testing. At other scientific meetings, I feel like people have talked about PCR, and I just wanted to know if there's any
Like the role
for it. Yeah.
Yeah.
Is there any role for it at any particular time in syphilis infection that might be the most useful for it?
Yeah. So thinking about nucleic acid amplification in syphilis in general, at the blood testing level, usually bacteremia does not get high enough for us to directly detect it, even through amplification methods. I think there has been some research, and I'm going to admit that I'm not completely up on the most recent literature on it, in considering like next-gen sequencing to be sensitive enough for that, which feels like it might be a little bit of overkill. PCR or other direct methods like dark field microscopy are possible when there's either rash or chancre and we're using like a swab specimen. That's really the major place where that has applicability. There is kind of ongoing research in neurosyphilis and how helpful that is. I think for most of what I've read more recently, VDRL in CSF is still considered the most accurate. Nucleic acid testing is helpful if you find it to be positive in CSF, but negative is not helpful for negative predictive value. Thank you.
Yep. All right.
Hi there. You mentioned that the CDC has suggested that women get tested 3 times during pregnancy. What's the benefit of 3 tests over the course of a pregnancy?
Yeah, so 3 tests during pregnancy, I will clarify, my state has said we have to have 3 times. I am not sure if it's in the CDC laboratory guidance. I don't know if you know for sure.
Yeah.
Okay. So the thought is that in the population that we're seeing become positive for syphilis, we don't have a good estimate of when they're becoming positive for syphilis. So by checking them regularly throughout pregnancy, we're reducing the risk of ending up at labor with syphilis. Part of that is also going to be the longer mom has syphilis, the more likely is she is to transmit it to her baby. To their baby. And the sooner that we can get treatment, the better. So if we only do one screen kind of just before labor and mom contracted syphilis month 2 of pregnancy, then we have a long time before we're actually getting that treated.
So it's one of the, yeah.
In the area of HIV prep and now with doxy prep, are we seeing, do you think we're making steps forward or back when it comes to elimination of syphilis in key populations?
Yeah, so I believe the question, correct me if I'm wrong, is with the use of PrEP and kind of the newer iterations of it, are we seeing changes in how that affects syphilis, incidence of syphilis, and how that's going?
Right.
In key populations, yeah. So we are still seeing, while syphilis is a problem across populations, we're still seeing it disproportionately affect minority populations. Our MSM population is still a population where we're seeing a continuing increase in syphilis. And I haven't seen any data that links that to PrEP or to kind of any other current HIV treatments that we're aware of. I don't know if there are epidemiologic studies that have looked too far into that.
I've read of 1 or 2, and I think there is a linkage more to behavior than it is to the PrEP treatment itself. So, you are on PrEP, and so you let your guard down and you behave in a more risky fashion, and so you end up with more STIs. So yeah, we need to educate better on the differences between some of these spirochetes and viruses, what protects for what.
So I will say there is guidance It may be from a professional society, but I believe it is from the CDC that patients who are at high risk and patients who are on PrEP be screened quarterly for STIs, including syphilis. And so that is part of the guidance to make sure we're treating people quickly.
All right. Well, we're at the end of our time. I really appreciate all of your questions. I'm sure we'll be available to discuss anything further, but thank you very much, Dr. Wheeler.
Thank you so much for having me. It's been a pleasure.
Yep.
I appreciate it.